Welcome to the Depth Dive. Today, we're getting straight into a really key topic for your MSRA revision, extradural hematoma, EDH.
Yeah, definitely high yield. We're aiming to give you a focused rundown based on those revision notes.
Exactly. Cut through the noise, make it stick. We know you might be feeling a bit swamped, so this is about clarity and quick recall for the exam.
That's the plan. Make EDH feel manageable.
Okay, let's start with the basics then. What actually is an extradural hematoma?
So, fundamentally, it's a bleed, a collection of blood that gathers in the space between the skull itself and the dura mater.
The dura mater, that's the brain's tough outer membrane.
Precisely. And the most common reason this happens is trauma, usually causing a tear or rupture in the middle meningeal artery.
Right. You sometimes hear it called epidural hemorrhage too, don't you?
You do, yeah. Same thing. And if it happens near the spinal cord, it's called a spinal epidural hematoma.
Got it. So delving into the causes, the etiology, it's mostly trauma.
Yeah, head trauma is the #1 cause. Often there's a skull fracture involved, especially one that crosses over that middle meningeal artery.
Okay.
But it's not always the artery. Sometimes bleeding can come from the dural sinuses. Those are big veins, or even tiny vessels in the skull bone itself, the diploic vessels.
And are there specific fracture types we should really link with EDH?
Definitely. Fractures of the temporal or parietal bones are classic culprits because the middle meningeal artery runs right along there.
Makes sense. It's vulnerable.
Exactly. And it's rarer, but you can get bilateral EDHs, like from really long fractures crossing the top of the head near the superior sagittal sinus, or even after certain brain surgeries, like a decompressive craniectomy.
Interesting. Is there anything different about kids?
Yes, actually. A key point for pediatrics is that children are often less likely to have an associated skull fracture with their EDH compared to adults. Their skulls are a bit more flexible, you see.
Ah, okay. That's a good distinction. And what about spinal EDHs? Are the causes similar?
Well, trauma can cause them, for sure. But there are other things, too, like medical procedures. Epidural anesthesia or even a lumbar puncture can sometimes trigger a bleed there.
Really?
Yeah. And sometimes they just happen spontaneously, maybe linked to problems with blood clotting, coagulation issues or platelet defects.
And location-wise, anything different with age for spinal EDH?
It's generally rare in adults, but interestingly, in kids, if they get a spinal EDH, it's more often found in the posterior fossa, that area at the back of the brain.
Okay. So if head trauma is the main driver, who's most at risk? What are the key risk factors?
Well, the biggest one is just significant head trauma itself. So think falls, car accidents, assaults, anything causing a hard knock.
Contact sports too, presumably.
Absolutely, yeah. Contact sports increase the risk.
Yeah.
And then there are medical factors. People with coagulopathies, bleeding disorders, or those taking anticoagulant drugs are more susceptible.
And age. You mentioned kids have fewer fractures, but does age play a role otherwise?
It does. Older people might have slightly more fragile blood vessels, making them a bit more prone to bleeding after an injury.
Right. So the vessel gets damaged by the trauma. What happens next? The pathophysiology.
Okay, so the trauma damages a blood vessel, usually that middle meningeal artery. Bleeding starts. Now, the dura is stuck pretty tightly to the inside of the skull, right? So the blood collects in that potential space between the skull and the dura. And as it builds up, it forms a hematoma, a clot, that starts pushing inwards.
Creating pressure on the brain.
Exactly. It acts like a growing mass, compressing the brain tissue underneath. And it's this pressure that causes all the neurological symptoms and problems. It's essentially a rapidly developing pressure problem.
Pressure problem. Good way to think of it. Now, clinically, when someone comes in after a head injury, how do we work out if it's EDH versus something else? The differential diagnosis.
Yeah, that's super important. Because several things can present similarly after head trauma.
Yeah.
You got to consider subdural hematoma that's bleeding under the dura.
Okay, different space.
Different space, yeah. Then there's epidural abscess, which is infection, not blood, in that same extradural space. Subarachnoid hemorrhage is bleeding around the brain surface. Intracerebral hemorrhage is bleeding within the brain tissue itself.
And just bruising.
And brain contusion, yeah, basically a bruise on the brain. So you need good clinical assessment, looking at the timing and pattern of symptoms, and crucially, imaging.
Which usually means a CT scan first.
Usually, yes. We'll get to investigations shortly.
Okay, before that, what about how common this is, specifically in the UK? Epidemiology.
Right. In the UK, the incidence is roughly 4 cases per 100,000 people each year. So not incredibly common across the whole population.
But significant when it happens.
Very. Mortality really varies depending on how bad the bleed is, other injuries, and crucially, how fast they get treatment. Overall, EDH happens in maybe 2% of all head injuries,
Okay.
but it accounts for something like 5 to 15% of fatal head injuries. So it carries significant weight.
Wow. Are there any demographic patterns in the UK?
Yes, definitely. It's much more common in males, about a 4-to-1 ratio.
Okay.
And age-wise, it's actually a bit rarer in very young kids, maybe because their skulls are more pliable, like we said. And also less common in people over 60, perhaps because the dura sticks more tightly to the skull then.
So there's a peak age.
Yeah, the peak incidence in children tends to be around 11 to 16 years old.
Right. And those spontaneous spinal ones.
They tend to show up most often in people in their 40s and 50s. And unfortunately, prognosis generally gets poorer with increasing age.
Got it. Okay, let's move on to how someone with an EDH might actually present. The clinical features.
So the story usually involves head trauma, often quite clearly. Now, you might have heard of the classic presentation.
The lucid interval.
Exactly. Initial loss of consciousness, then they wake up, seem okay for a bit, that's the lucid interval, and then they start to deteriorate neurologically.
But that doesn't always happen.
No, definitely not. It's actually a minority pattern. Much more commonly, patients might just have a really severe headache, feel sick, vomit, seem confused, or have a fluctuating conscious level. Seizures can happen too, or focal neurological deficit.
Like weakness on one side.
Yeah, weakness, numbness, that sort of thing.
Are there any real red flags we should be watching out for, signs that scream worry about EDH?
Absolutely. Rapid deterioration is a huge warning sign, especially if the bleed is in the posterior fossa at the back. Also, watch for bradycardia, slow heart rate sometimes with high blood pressure. That's Cushing's triad starting, indicating raised intracranial pressure.
Okay.
Obvious signs of trauma, like skull fracture, scalp hematomas, or cuts, are relevant. Leaking clear fluid, CSF, from the ear or nose that suggests a skull base fracture.
And neurological signs.
Unequal pupils are a major red flag. Facial nerve weakness, limb weakness, all point towards significant pressure effects.
And for the spinal ones.
For spinal EDH, it's all about cord compression. So you're looking for weakness, numbness, altered reflexes, maybe bowel or bladder incontinence.
Okay, so we suspect it based on the presentation. What investigations do we order?
Right, the absolute first-line go-to investigation is a non-contrast CT scan of the head.
Why non-contrast?
Because blood shows up bright white on a non-contrast CT, making the hematoma easy to spot. It typically looks like a lens shape or lenticular pushing in from the skull.
Okay. Is MRI ever used?
It can be. It's sometimes better for looking at older, chronic hematomas or if you need more detail later on. But in the acute setting, CT is faster and excellent for diagnosis.
Any blood tests needed?
Yeah, definitely want baseline bloods, FBC, UNEs. And if you have any reason to suspect a clotting problem, or if the patient is on anticoagulants, you absolutely need coagulation studies. Platelets, too.
What about x-rays?
A skull x-ray might show a fracture, but the CT is much better for seeing both the bone and the bleed. A cervical spine x-ray, or more likely now a CTC spine, is crucial if there's significant trauma mechanism to rule out neck injury.
Makes sense. Trauma assessment.
Exactly. And if the patient deteriorates, you might need to repeat the CT scan. MRI is really more for stable patients or follow-up.
Anything we should absolutely not do.
Yes. Avoid a lumbar puncture if you suspect raised intracranial pressure before you've done imaging. Doing an LP with a mass lesion like an EDH can cause brain herniation. Very dangerous.
Right. Critical point. Okay, we've diagnosed it with the CT. How do we manage EDH?
First things first. Stabilize the patient. ABC's airway, breathing, circulation, especially if they're unconscious. Protect the airway. Crucial neck care, assuming potential C-spine injury. Full trauma assessment for other injuries. Maybe IV fluids to support blood pressure.
And then tackling the hematoma itself. Is it always surgery?
Often, yes, but not always. Surgical evacuation is the mainstay for acute, symptomatic EDHs, usually via a craniotomy, opening the skull, or sometimes smaller burr holes.
Is there a size threshold?
A common guideline is that surgery is generally needed if the hematoma is bigger than about 30 cubic centimeters, pretty much regardless of their GCS score.
But sometimes conservative management is possible.
Yes, for small hematomas in patients who are fully alert and asymptomatic, and where you can monitor them very closely, observation might be an option. Some centers might even consider it for larger bleeds if the patient is completely stable, but that requires careful judgment and close monitoring capabilities.
What about that raised intracranial pressure? How do you manage that?
If the pressure inside the skull is high, we can use things like osmotic diuretics, IV mannitol is common, or hypertonic saline solution. These help draw fluid out of the brain tissue.
Okay.
And it's a multidisciplinary effort, right? You need to manage any other injuries, any underlying health problems, and be really careful with anticoagulation. Maybe use TED stockings for DVT prevention instead, if possible.
Right. So what's the outlook, the prognosis for EDH?
It really varies. Key factors are the hematoma size and location, the patient's age, their general health, and this is critical how quickly they get treated.
What sort of mortality rates are we talking about?
It can range anywhere from about 5% up to maybe 30%. Prompt surgical evacuation generally leads to an excellent prognosis if done early.
Does age make a big difference?
It does seem to. Outcomes tend to be poorer in older patients, say over 75, with an acute EDH. Overall mortality sits around 30%, but it's much worse if the patient comes in with a very low GCS score.
Are there specific factors that predict a worse outcome?
Yeah, things like older age, having other bleeds inside the dura as well, intradural lesions, a really large hematoma if it's in the temporal lobe, because that can cause rapid herniation, quick deterioration, pupil abnormalities, and that high intracranial pressure we talked about.
And even if treatment is successful, there can be lingering issues, complications.
Unfortunately, yes. Neurological problems can sometimes persist, maybe temporary, maybe permanent, and sadly, death is a possible outcome.
What about seizures?
Post-traumatic seizures can develop, often like 1 to 3 months later. The risk seems higher in people with alcohol dependence. Interestingly, giving anti-epileptic drugs prophylactically after mild TBI doesn't seem to prevent these later seizures.
Any other delayed effects?
Yeah, some people get post-concussion syndrome, ongoing headaches, dizziness, feeling emotional, fatigue. And for spinal EDH, complications can include things like muscle spasticity, neuropathic pain, or bladder and bowel issues.
Okay, that's a lot to take in for revision. Any quick memory tips or mnemonics for EDH?
Definitely. For the location, remember, Skull-Dura EDH. It's extradural, outside the dura.
Skull-Dura EDH, got it.
Remember, the lucid interval is classic but not common. Don't rely on it being there or not. Think middle meningeal artery, MMA, as the main culprit.
And MMA.
Link temporal bone fractures to that MMA damage, they're close neighbors. And the core issue, it's a pressure problem. The expanding blood presses on the brain.
Pressure problem. Good hooks. How about we try a quick practice question?
Sounds good. Okay, imagine this. A 30-year-old rugby player gets knocked out briefly. He seems okay on the sideline for maybe an hour, alert, talking. Then he develops a worsening headache, gets really drowsy, and you notice his left pupil is bigger than his right.
Okay. Trauma, then that period of seeming okay. The lucid interval, possibly?
Could be.
Then the drowsiness, the headache, and the unequal pupil suggesting raised pressure.
Yep.
It sounds very much like an extradural haematoma. Most likely diagnosis EDH. And the first investigation has got to be a non-contrast CT scan of the head. Immediately.
Bang on. That scenario hits all the key points. Trauma, lucid interval maybe, deterioration, signs of raised ICP. Perfect example.
Great. Well, that wraps up our deep dive into extradural haematoma. Hopefully that's made it clearer for your MSRA prep.
Yeah, the key takeaway is it's time critical, usually follows trauma, needs that urgent CT, and often requires surgery. Knowing the features and management is vital.
Absolutely. So review your notes, maybe use those memory tips we mentioned.
Definitely reinforce the key concepts, Skull-Dura EDH, MMA, pressure problem.
And for loads more MSRA revision resources, do you head over to passthemsra.com.
Yeah, great site. And also check out freemsra.com for some excellent free study materials as well.
Okay. And one final thought to leave you with. Think about why an EDH might present differently or even be less common in a very young child compared to an older adult. Consider how tightly that dura is stuck to the skull at different ages. Something to ponder.
Good one. Food for thought.
Thanks for joining us for this deep dive.